Well, I want to thank Alma Villa and the staff here for actually having scones this morning and coffee and decaf coffee and tea. It's a nice way to start the morning, so thank you. All right, I want to remind people that we're filming today, and we're filming at our commission meetings from now on, so no surprises. I would like to introduce our speaker, Grant Colfax. But let me tell you a little bit about Grant. Dr. Grant Colfax is the Director of Health and Human Services for the County of Marin. Oh, I'm sorry. Come on in. I was just going to say, I said thank you so much for the hospitality. It's wonderful. Great. Welcome. Let me give you a little background about Grant, because he comes from quite an experience. If you don't know anything about Dr. Colfax, you'll find this very interesting. He's the Director of Health and Human Services in Marin County, and for the past 25 years, Dr. Colfax has strived to improve health and wellness through his work in clinical medicine, research, policy, and administration. A graduate of Harvard Medical School, he completed his residency in internal medicine at the University of California, San Francisco, and in 1997, joined the San Francisco Health Department, where his focus was on research and implementing HIV prevention interventions. As a director of HIV prevention and research, where I met Grant so many years ago, he emphasized bringing an evidence-based, community-informed approach to addressing gaps in HIV care and prevention. From 2012 to 2014, he was a member of the Obama administration, serving as the director of the Office of National AIDS Policy, where he served as the president's primary advisor on domestic HIV policy and coordinated federal efforts to implement national HIV/AIDS strategy. In May of 2015, Dr. Colfax became the director of the Marin Health and Human Services, leading the country's public health, social services, the county's public health, social services, and mental health and substance abuse services for this county. Dr. Colfax has mentored multiple students, researchers, public health professionals, and has been awarded numerous grants from the National Institutes of Health and Centers for Disease Control. He has authored over 80 peer-reviewed publications. Let's welcome Dr. Grant Colfax.
Well, good morning, everybody, and thank you, Terry, for that introduction. I really appreciate it, and it's really great to be here with all of you. But first things first, is anybody from Chicago here? So congratulations, and my condolences to the folks who may be from Cleveland. But that was quite I'm not really a baseball fan, but even I was like, wow, this is like unbelievable. Unbelievable. Talk about performing under pressure, right? So, and I guess, next even year we'll be up there, right, again. So, it's great to be here. I really want to thank the Commission for inviting me. And one of the great things about having, I think I'm going to try to move around here a little bit. So, being here for the last year and a half is meeting many of you and thinking about where we're headed for the future. And I just also want to thank the staff, particularly in our aging team, for helping prepare this talk and informing me about, what are the issues that you all are thinking about and struggling with as we move forward. So I have a number of slides. I thought I'd go over them and then we could have a discussion afterwards, and I want to be respectful of your time, but I actually can go a little bit over if you all would like to do that, so we have some conversations. And then we'll also send the presentation out if it hasn't already been sent out, but I thought it would be good to have you look at this rather than looking down at a handout and trying to balance my conversation with the slides themselves. So I'm going to just talk in general and then focus a little bit about what we've been doing in the department in terms of our new focus moving forward. But I think you all probably know this, that Marin County is fortunate enough to rank #1 in health of all the California's 58 counties. And this has actually been for the last 7 years. And obviously, many of you have had a lot of effect on this, and I want to thank you for that. My predecessor, Dr. Larry Meredith, has was one of the major contributors to this, plus the many partners in the county who are really focused on health and wellness. So the good thing is we're number one. The good thing is we're very highly ranked in terms of mortality in the nation. Marin is actually number one for life expectancy of women. We have a pretty amazing number of life. This is median life expectancy, right? So 85 years, pretty impressive. Men, we're not doing quite as well, but there's only a 0.27 difference between the top and number 5. So that's about 2 months, which matters, I guess. But we're still doing really, really well compared to the rest of the country. But so one of the questions when I was looking at this position and I've lived in Sausalito for 17 years, and so I grew up north of here, so I have a sense of our sort of cultural norms and the focus on health and wellness. But one of the questions is, well, what would you do in health and human services, and what are the needs? Obviously, our aging population is a challenge, and I think a really exciting opportunity as we think about how do we become a model for aging well, not just for our own communities, but for communities across the country. And then we also have really severe issues around equity, health and wellness equity. And I'm saying health and wellness equity because a lot of times people talk about health equity, but I think it's really around health and wellness equity. So health is obviously, health is defined as the absence of disease, but wellness is defined as the experience of a balanced and rewarding life. So I think that we need to focus on health and wellness together in terms of our health equity. So the other thing, this is just a chart to remind us that equality does not equal equity. And health and wellness equity is really the attainment of equal health and wellness in a culture, irrespective of one's status in that culture. So irrespective of income, irrespective of prestige, power, and wealth. So it's really a focus on, it's a concept, an aspirational concept, where no matter what you make or your educational level, that your health and wellness is equivalent to other people in the community. It does not mean that, everybody to be healthy and well needs to make a 6-figure income, or everybody to be healthy and well needs to have a PhD. And I think that's something that we need to keep in mind as we think about the challenges of addressing health equity. And it also doesn't mean equality. And this schematic helps me remember when we're talking about equity, the difference. Equality means everybody gets the same thing, right? Equity means that we recognize, and this is actually a judgment, if you will, a social justice perspective, that equity means giving some people more who need more, right? So these folks are of different height here in order to reach the apple. If we just focused on being equal, not everybody would be able to reach that apple. But if we focused on giving people who need more and more, we would be able to actually achieve that. And that's something that it reaches across not just health and wellness, but also things like education, right? So Mary Jane Burke, our superintendent of schools, really focuses on the idea that some kids in some communities need more to do the same. And that's something like Measure A, which is something you'll be voting on next Tuesday, would potentially bring us in Marin County in respect to education. So in terms of equity challenges, and I know some of you know this, but I just think it needs to be repeated, your zip code in Marin matters a lot more than your genetic code. So there's a 17-year life difference in different communities. If we look at the longest lived communities in Marin versus the shorter lived communities, 17 years. So think about that in relation to those mortality data that I just showed you. On average, we're doing really well. But as an epidemiologist, I talk to folks and students about the danger of looking at just an average, just the mean, right? There's the tyranny of the mean. You got to dig below the data to see how these things are distributed. We have a 40% higher heart disease rate in some communities compared to our wealthier communities in Marin. This is Marin City, so if we look at why people are dying younger in Marin City, it's 40% of that is explained by cardiovascular disease. And then I think, again, going just beyond the health and wellness issue, but thinking about income inequality. This is a big issue in the campaign. It's a big issue nationally right now. We rank 54 out of 57 in terms of growing income inequality. The bottom 20% of our adults in Marin make 1.2% of the total income. And if you look, this is increased. I mean, compared to the 50s and 60s and even the 70s, this gap has increased dramatically. And you can draw a line. If you look internationally, you can draw a line between, there's a direct relationship between health and wellness and income inequality. The countries that have the biggest inequalities have the worst health and wellness outcomes. It's actually quite remarkable. So this slide with regard to the middle line, I think you're all pretty familiar with, or you should be in terms of the Commission on Aging. The middle, I think it's blue. Is it bluish? Purplish, okay. Purplish, the middle line is the number of older adults in Marin County that we're projecting from 2000 all the way to 2050. So older adults in this graph are defined as being 60 or over. You can see, I think if I point, yeah, there you go. We expect well, that's what I was afraid of. It's giving it all away. Okay, let me try that again. I think I just slipped my thumb. So we expect people 60 or older to peak, the population to peak in 2030. We're somewhere right between here now, so we're on the upward projection. And this is a really important point to look at and to think about how do we prepare for the aging population, particularly with regard to the drop in adults between 20 and 59, and then our somewhat stable but a little bit declining in terms of the number of youth. But I asked for us to look at these other numbers of other populations as well, because I think there are a couple of points. A lot of times the conversation sort of stops here. Well, it's because I keep flipping it. I'm giving it. Okay. My thumb is just too big. The conversation tends to stop here. And I think the question is, how do we think about the community building, the cultural relationships, the infrastructure we're building to obviously prepare for the peak of the population over 60, but think about beyond that as well. And I don't have the answers to that necessarily. We have a few more years to think about it and consider it. But this increase in the aging population as the baby boomers age, then there's going to be a tail, and then there's going to be a drop-off. So as we think about what are the buildings we need to consider, what are the communities we need to build, we have to think beyond just the peak. We have to go further and think about what are the policies, programs, infrastructure we need to build to be prepared for that. So I talked about income inequality. I also want to really emphasize the importance of income insecurity among older adults in Marin. One of the challenges in such a wealthy community where we have one of the highest median incomes in the country is the federal poverty level of 10,830. So when you apply for many social safety net programs, right? If you live in Marin, if you live in Oklahoma, if you live in Alabama, Idaho, this is your income. The $10,830 is the income that you're looked upon to say, okay, are you eligible for these programs? So that, just on the face of it, is ridiculous in terms of if we think about, and if we value having a heterogeneous community, a diverse community in terms of income. We actually, and I know some of you were involved in this, we estimate for an older adult renting property, the minimum they could they would need and qualify for other safety net programs is $27,334. So that's over twice the amount of the federal poverty level. And this is not living well. This is really barely hanging on. This is the equivalent of the federal poverty level. So I don't want you to think that this is, even a lower middle class existence, or even this is poverty. So that's really a challenge for us. And when we think of, people say, oh, well, there are not very many older adults in Marin who are at the federal poverty level. That's actually true. There's still too many, but it's 6%, right? But if we use this other number, it really increases our number it more than doubles the number to over 10,000. And I think that number is going to go up, right? It also doesn't take into account the nuances of growing older in Marin, owning your own house that might be worth, a lot, but you actually have very limited income coming in, and that's another key thing. So just a nuance that gets lost again if we just consider the averages, if we just consider federal policies and so forth. This is a huge challenge. I think it's a moral challenge too. I think it's a question, at the national level, having been involved in both local and national policy. What does the federal poverty level mean, and how do you deal with that, especially in communities where seeing incomes be so diverse? And I'm sure I have many friends, and I'm sure you have friends who have moved away from this community because they can, survive in other places that are less wealthy, which is okay, but that really means that we're going to change our basic fabric as well. So this is just saying what I keep emphasizing around the importance of income and wealth in relationship to life expectancy. This is the relationship between average life expectancy and income by California counties. And again, as you would guess, Marin is at the top. And then we see, other counties that are not very far away from us. Lake, which is way down here. So look at that. There's almost a decade difference in life expectancy. I mean, these are epidemiologically massive numbers in terms of a whole decade of life lost if you drive 100 miles north. It's pretty interesting. So this is a complicated slide. I'm going to take a minute to talk about it. But when we think about life expectancy, when we think about health and wellness, so much of our work and resources go into the care, direct delivery of services, right? And the care model of providing, care for people who've already developed diseases. And I just want you to think about this. 80% of health and wellness is explained by socioeconomic and behavioral factors. And you can just use, about 40% is behaviors. So 40% is things like smoking, drug use, other behavior, exercise, so you have good behaviors too, right? But about 40% is explained by behaviors. About 40% is explained by socioeconomic environmental factors. So do you live in a place where you can go walk? Do you experience stigma as a person of color in a community? Gender issues and gender norms. So about 40% are those issues. And then only 10% is actually what we think of as direct medical care. Which is why when I trained as a physician, I was like, well, this is actually this is a very small part. Now we have some things, vaccines, for instance, where it's amazing. Like you look at the smallpox, direct medical care vaccinations. Those are actually in many ways the exception to the norm about how we're trying to invest our resources. We spend more money for keeping people in the ICU than we do in thinking about primary prevention. Only 3% of the federal budget, medical budget, is spent on prevention. 3%. 97% is spent on the rest of it. And the ACA, the Obamacare, moved us a little further into the prevention aspect. It's really, and even that's been very disruptive, right? But we have a long way to go. And the other piece, the other component, so 40% behavioral, 40% socio-environmental, 10% medical, and then 10% is genes. So only 10%. There's a lot, especially with our bio companies here, and it's fascinating. Sometimes it can be really significant. If you have the genetic disorder of sickle cell, that's going to affect your mortality dramatically. But for most of us, these things are not nearly as important as our behaviors and our social environment. So so we can all look at the slide, but this is where we're down. So we talk about being downstream, right? So we think about these issues in terms of focusing on disease and injury. We're doing a little better on risk behaviors, and Terry and I did a lot of this in the AIDS office in San Francisco. Smoking, poor nutrition, but the living conditions are increasingly important. So current practice, and this is a slide that's a public health framework, but I think the slide's wrong. I think it's a framework for health and wellness overall, because if we think about our social services as well and what you all do on the commission, which I would encourage you to think way beyond just the social service aspect, but to think about the public health aspects, the behavioral aspects. Think about this chart when you're doing your work. We really need to move more upstream to think about the living conditions, right? The physical environment, institutional inequities, right? So we're talking about how different agencies can work together to improve health and wellness. Don't usually do it, don't usually have that focus, but what can we do there? And then even further up to the social inequities of class, race, ethnicity, immigration, gender, and sexual orientation that drive a lot of our work downstream. So one of the things that I've been working on with folks in our department and across the county is how do we think about moving more upstream? It's a very hard thing to do. Many of our programs are financed very downstream. We are basically straitjacketed about what we can and cannot do. But I think one of the first things we need to do is change our culture, both in the department and somewhat in the county with various stakeholders, about how to even think about these things. So if you are providing very important care to kids, medical care, you have that broader perspective about what that person is experiencing and how they may, how you might address some of their issues. I'll just give you a very specific example. In Marin City, working with the Marin City Health and Wellness Center, we have a pilot project where the clinicians are actually giving people prescriptions to go walk in parks, right? So that's not a huge shift, but if you think about living conditions, right? Marin City just got their first park for 35 years. Suddenly there's actually a place where you can walk, right? There wasn't that before. So I just think that's a very small but tangible example, and we're working on that in the department to think about how do we shift our culture of thinking, and then the programs and the work will follow. The flexibility, I think, will follow over time. There's a lot of interest in this right now, and depending on what happens next Tuesday, hopefully we'll be able to continue to move forward on this. So we actually are developing a strategic plan under those, with that lens, and I think there are 3 other pieces of the strategic plan that we're developing. Well, let me step back. First of all, HHS, Health and Human Services, has never had a comprehensive strategic plan. We've had lots of good plans that are specific to populations or specific divisions or departments. The aging plan that you all worked on is one of those key things, and but we've never had a comprehensive approach that says, as a department, we have public health, we have behavioral health, we have social services, all under one department, which is a huge opportunity, also a challenge. Public health has different areas that they work on. Behavioral health has their own plans. Social services has a number of specific plans to specific populations, including yours. But there hasn't been a meeting of the different microcultures within our organization to figure out through this concept of social determinants of health, where do we go? Where do we need to work together to be more effective? So that's one of the key things we're doing in this plan. For the first time, we have people strategically thinking about prioritizing the work of the department and how do we partner with the county in the broader context of this umbrella of the social determinants of health. 3 things. One is a focus on equity, right? So I talked about that. 2 is becoming more data-driven. So how do we really look at the data and figure out not only where the challenges are, but how do we turn the curve on some of those challenges? What is the evidence that there's some things we can't do anything about. There's some things we can do a lot about. And there's that middle area. So really focusing on that. And that's really focusing on becoming more evidence-based, right? So how do we become a more evidence-based department so that we have limited resources and we want to make sure that we're investing those resources in the most effective products. So right now we're in the area we're prioritizing the data that we're looking at. And just to give you a sense of what's happened in this group, they've reviewed over 300 surveys that have been done within the department in the past 5 years. So there's a lot of data out there that has, it turned out that people were doing surveys of the same question that had been done in another group that they didn't even know about. We have 700 employees. There's a lot going on. But for the first time, we inventoried this, and we're prioritizing and then crafting a plan, and we'll implement it once we have the actual strategy developed. But I will tell you, we're going to come to the commission and to all of you for a broader conversation about how do you see yours, and I hope we can have a little bit of that conversation today, but here's what we're thinking of, here's what we found, how do you respond to that, what do you think is needed going forward, here's some ideas that we're thinking about trying, here's some approaches. So we'll have that conversation with you, I think sometime within the next probably 6 months, and so we'll just make sure that we have this group as a focus group to give us that input. And this plan is for the department. When I got here, I was thinking we need to do a whole plan for all of Marin, and where we have a plan that's not just, where the department's not just the primary focus, but it's for the whole county, and other counties have that. We are not ready for that as a department yet. We need to figure out what our own goals and principles are so that we can then strengthen our structure to then reach out in a more comprehensive way to other key stakeholders to build the broader strategy. And so it's just a judgment a call I had to make, but I thought that we were clearly one of the key leaders in that, and we weren't ready for that yet. So this is just to give you a sense of our strategic plan framework. We've actually identified the population 0 to 5 all the way to 60 plus. So this is basically the whole lifespan. So it's not as though these populations are prioritized because everybody got in, but it is an example of how we're thinking it. We're taking a lifespan approach to how we think about approaching the needs of these specific populations, right? So kids 0 to 5, for instance, most of the research shows it's all about early childhood education. It really is. You vaccinate them, you get them early childhood, and then you do early childhood education, and that's the strongest predictor of studies going back all the way to the 50s of later life success, regardless of baseline economic development. So we maybe will be focusing on something like that. I'm really simplifying here, so forgive me if I'm being overly glib, but I just think sometimes it's helpful to stand back and say, okay, where are you really going to focus these issues, right? So children 6 to 4 and youth, there we go again. For children 6 to 12, youth 13 to 24, especially youth 13 to 24, right? What's there? Tobacco, drugs, frontal lobe craziness, right? Try to help balance that and get people the care they need in order to make that happen. And also realize that there are young adults that have serious mental illness in addition to just the normal, and I say the crazy teenage brain where you're really not, you have all this frontal lobe development that's happening and all the different hormones and there's actually clear evidence that the things that, and I don't have kids, but I know many of you probably do, and I know as a teenager I was kind of crazy, and so, but there's actually really strong biologic evidence that supports all the experiences that those kids and their families have with them as they're developing. You're just not, you're in a very vulnerable space, right? You're in a very vulnerable space, and your receptors have not fully developed yet. So if you start feeding off of alcohol, nicotine, other drugs at that stage, it's very hard to break that pattern later in life. So we really need to think about how do we do more prevention with youth. And then adults 25 to 60, it's really behavioral health. It's really the mental health side of things that are very, very important there. And so I think we'll be focusing on a lot of our work there. And the adults 60 or over, I want to hear from you. Obviously, I'm going to talk about some of the things that we've looked at and how it relates to the priorities you've already set in your plan. And I'm going to keep going, but I do think it's just also important to realize that beyond the lifespan, we've identified some key populations where the disparities are significant, and that's why we're going to dig deeper in those specific populations regardless of their age. So emerging priorities across the populations, I don't think these will come as surprises to you. I'm going to go through some of these later, so I'll just skip this because I want to make sure we do have time for more conversation. But I want to point out this is a schematic. There's no actual data on here, but this is something that our team is really trying to think through and balance here. We're looking and focusing on improvements in health equity, right? So that's a critical value, and I think from just a social justice perspective, that's something incredibly important. We also have a role where we look at population health, right? So the broader health of the population, which is beyond specific health equity, right? So let me give you, it's helpful just to think about a concrete example. So if we focused on Marin City, for instance, which again, as you saw, 40% higher cardiovascular rate disease, real differences in life expectancy there. That's a relatively small community in Marin. It's about 2,500 people. It's 1.5% of our population. If we go deep there, we can make a huge difference in health equity. It's not going to move the button very much in terms of the overall population health of Marin. I think that's okay because there's, again, that issue that we have to go deep. But sometimes we have to go broad as well. For instance, in our public health side, we need to work and make sure that all kids are vaccinated in Marin, right? So that's a population health issue. Another example I would give, for instance, is looking at the issue, substance use, right? Do we go deep and focus on the poorest and the most marginalized that also have substance use issues, or do we go broad and think about the fact that in our metrics, the statewide metrics, Marin County is very high in binge drinking across all populations. So I don't think it's an either or, but I just wanted to share with you the tension, and it's a good dynamic tension, and I don't mean tension in a bad way here. But sometimes we're going to go focus on things that are very deep in certain communities around health equity. Sometimes we go broad with population health. The sweet spot's here, because then you're shifting health equity and population health, right? We're probably not going to focus down here because you're just not going to be doing much of anything. But just even having the schematic helps us think through strategically how we balance our work. So this is some of the data that's been explored for older adults in Marin. And again, I'm not going to read through this, but just to give you a sense across our different divisions for the first time. I mean, sometimes there are people in here who would, beyond our aging team, which is a great team, but a relatively small team compared to the rest of the department. Suddenly you had public health folks, you had epidemiologists, you had behavioral health folks, looking at this through the lens of thinking about the data for older adults. So again, really shifting our culture in terms of working more intentfully together. For older adults, these are some of the things that have really been identified as emerging themes in the plan, and I want to make sure that, one, to emphasize that this is not final. There is no plan yet. So I'm giving you sort of an inside picture of the things that have bubbled to the top at this point, but this could easily change partly on your input and partly on other input that we're going to get as things evolve. Again, I don't think there'll be surprises here for most of you in terms of what's emerged. And in fact, these concerns are very align very well with the aging survey, top 6 concerns that I know that you all worked on, as well as the Aging Action Initiative, right? So they're not surprises here so much, and that's okay, but it's really a way for us to synthesize the information in a more intentful way and then say, okay, how are we going to look at a specific issue and really address it in a meaningful, with meaningful programming through a data-driven, equity-based lens, for instance. So I wanted to just give you a concrete example, a small example, but a concrete example of how we're thinking about falls within the department, because I know falls was one of the number one issue, thank you, focused in the survey, and over half of falls happen at home. So, and this is something that we've also identified partly because of your work. So we decided to take a real evidence-based approach to our preventing falls in older adults. And it's different from how we've worked before. We had an interdisciplinary health and human services convening where we reviewed over 159 peer-reviewed studies of falls and said, what really makes a difference in falls? So where do we want to orient our programming with our partners and think about what makes a difference, right? Because you could do lots of stuff. You could come up with lots of ideas. And these 3 multi-component exercise programs, Tai Chi and home safety interventions, were the ones that really made a difference. And some of you probably already know this, because I see some nodding heads. But the difference, a critical thing that happened in our discussion was education and pamphlets were not effective. And we actually had some people say, oh, well, that would have been the first thing I would have done, that we would have invested in terms of that sort of work. And I don't have time to go through the statistics, but this is intentful review, looking really carefully at the data to say what are the programs we want to support with our financing going forward. So this is a model, again, where we had the epidemiologist, the experts on aging coming together and really doing a deep dive into the data. And we're going to be doing more of this work as we develop a stronger data and analysis muscle in the department, across the department. So I'm going to switch a little bit to the mental health, and these are busy slides, and I will go through them quickly, but just to make sure that people really understand that the mental health side, the behavioral health side, and I think this goes along with the social isolation piece that has been identified as a priority as well, right? Only half of people are actually with over 55 are receiving the help they need with regard to behavioral health issues. There's still issues with regard to the cost. And in Marin, we have a terrible challenge of insufficient numbers of mental health professionals who accept Medicare and private insurance. So there's this strange paradox in Marin. If you're poor enough to qualify for Medicaid, you qualify for our behavioral health and recovery services programs. And while those programs are by no means perfect, they do provide a mechanism of support and care to help you. If you're wealthy enough to pay whatever the going rate is right now in cash for a mental health professional, you're also probably okay. It's really the middle group where if you have Medicare it's a big problem because people are just not taking those. So that's an example, again, where the equity issue, we're very clear on our equity role in the department around providing the safety net services for the Medicaid population. And that's not that doesn't keep me up at night, but what really keeps me up at night is what about the people who are, doing fine but can't pay $300 cash an hour? It's more than that now in some cases. And how do we provide those mental health services to folks, right? What does that mean? What are the systems? And this is a national issue. I mean, the amazing thing about Obamacare is it actually put mental health and substance use treatment on par with physical health treatment. Really revolutionary. We don't like to use that word in Washington, but it's like transformative is what we say. But the systems haven't caught up with that. The workforce hasn't caught up with that. I'm having a terrible time finding psychiatrists, even to work in our Medicaid population. The current rate at Kaiser right now for a beginning psychiatrist is $300,000 a year, $150,000 signing bonus, and $150,000 down payment on a house. So how do I go to the Board of Supervisors and say, okay, that's what we need here? So I just to give you a sense, and I don't mean to get too inside baseball here, but it gives you a sense of how we think about and what we're struggling with to provide even a safety net system in the county. So I'm going to skip this because it's basically what I said already, but I also wanted to really think about the other piece that's very integrated with behavioral health issues, which is Alzheimer's and dementia. And I'm going to use those words, and I know medically it's not correct, but I'm going to use those words interchangeably just for the sake of this presentation. So Alzheimer's is the 3rd leading cause of death in Marin, 6th leading cause across the U.S. Based on, partly that chart of the increase in the aging population, we're unfortunately going to see an increase in Alzheimer's and dementia in our county unless there's some transformative discovery. And it's a upcoming burden that's going to be really influential in terms of how we work. And one of the things that keeps me very concerned is how do we do a better job of integrating the behavioral health issues while that can also address dementia and Alzheimer's disease, because these are so so linked in so many of the challenges that we have. And the funding streams are so uncoupled. It's very challenging. So I'm going to talk a little bit about where we think we'll go in that direction and some opportunities there in a minute. And I also want it, because behavioral health is so related to substance use, I wanted to also bring into substance use into the picture at the same time here. This is just to show there's been a lot of focus on overdose deaths, right? Especially with prescription opiate deaths across the country. We've had a major issue here in Marin as well. What I think is less talked about is some of the mortality in older adults. We sort of focus on the young, right? Young folks a lot, but there's a lot of overdose happening here as well. So we need to also think not just about the mental health side from sort of the organic brain syndromes and the dementia side, but also how are we dealing with the drug use? And often this is prescription drugs that may not even be being abused by patients, right? So falls. So I was looking at the data on falls. The 60 plus population has the highest co-prescription of benzodiazepines, which are very related to fall risk with opiates. And that's never going to be, that's rarely identified as why somebody fell and broke his or her hip and then died, right? We'll get fall. And it's not technically an overdose, but it's all wrapped up in that connection. So I just think we need to think about the behavioral health side, substance use side, dementia side, not as sides, but as how do we deal with it? How do we orient our system towards that person rather than constantly asking people to orient themselves around our siloed systems? That's right now. You go here, you go there, and I'm dealing with this internally, culturally in the department. It's the diagnosis of dementia, so this is the number you need to call. But if it's mental health, you have to call this number. But if you have a substance use issue, you need to call this number. And that's not anybody's fault in the department. It's often because we can't get our drawdown dollars in reimbursement from the feds in order to provide a more comprehensive system. So I think one of the key ways we can start thinking about this, and there are opportunities coming forward, because increasingly the feds are realizing this, and it's not that they don't understand this and value this. The question is, how do you shift the work? And there are things going forward now, again, largely because of the ACA, where there's going to be more flexibility given to different counties in terms of focusing on outcomes and not just outputs. So it's not just a matter of how many people did you serve, but it's how did you make a difference in your community's health. One of the things we're excited about is whole person care, which is an opportunity to integrate our care delivery system. We're thinking that we would do this specifically around mental health, dementia, substance use, with potentially a focus, if not a focus, but very inclusive of the older adult population. And this would build on Project Independence, which I know many of you are familiar with, which Anna's group has done a phenomenal job in bringing forward. But how do we then potentially expand upon this? And this is really the wave of the future. Again, depending on what happens next week. Right now, it's the wave of the future in terms of looking at value-based care, and there's a recognition that in order to achieve the whole person care vision and to go more upstream, you can have these separately funded programs that are only looking at one outcome or one condition. It's going to be a long haul. This is something that's very hard to do. So this is, when I say the vision of the future, I'm thinking over the next decade, 2 decades. This is where we're gonna lead. So and the last thing that I just want to touch upon specifically around a broader issue that we don't always think about in terms of health and wellness is food insecurity among older adults in Marin. And 1 out of 5 adult people in Marin is actually food insecure, so it's actually a major issue. And particularly in older adults, there are various factors that are shown in these bubbles about why people might have increased risk of food insecurity. I know this has been prioritized from your data as well. But I'm going to get very specific for a moment because sometimes I get so sort of broad that staff are like, well, what do I do on my programming day to day? This is so in the future, what do we actually do? But one of the concrete things we're looking at, particularly with food insecurity in adults, is looking at the poor adults in our Medicaid program and saying, why are our CalFresh or food stamp enrollment rates so low within our own sort of locus of full control, if you will, right? Because we enroll, we have over 5,000 people over 60 enrolled in Medicaid, and only 20% of those are enrolled in the CalFresh program. And the reason that's important is because essentially all those folks are eligible for should be eligible for CalFresh. So we're actually delving deeper into that data and figuring out what are the barriers to CalFresh enrollment. There are issues around stigma. There are issues around knowledge. There are issues around, I mean, I don't know. I looked at the CalFresh application. It's literally like 25 pages that you have to fill out. It's just, so I think that there are issues around structural, and you know, if you're an older adult, how can you fill out a form like, if you're any person, how can you fill out 25 pages, right? So I think there's a lot of things that we need to think about, increasing our efficiencies and really monitoring our data. And again, this is something that takes us away from sort of that broader theoretical model to something that's very concrete that people can work on. And we can actually measure our outcomes fairly quickly here. Okay, so I'm going to go a little faster now because I realize what time it is, and Terry's pointing at her watch. So I just want to, so that's sort of the department perspective and where we're headed. I also just want to acknowledge that there's so many things that are happening in the county that we want to partner better with all of you on and other communities. And I think Sparky had to leave, or maybe she had heard this all before, so she left. But I think she was just talking to me about some of the work that she's been doing. I know many of you have been involved, and Sybil, you're very involved in the age-friendly Sausalito, so thank you for that, since I plan to age in Sausalito. I've been aging. So I think that there's some really important pieces around age-friendly communities, and I think some of these may have moved to approval. Does anybody know this? Okay, Corte Madera is there. Okay, so you made it, so we're there. Okay, so we'll move you. Sorry, this is... And I think some of these may have applied. So we'll make sure we update this. So congratulations. It's very important. The Marin Village piece, and Terry, you're involved in that, right? Sparky is. Sparky's very involved. I know many, yeah, there's a Marin Village cap. So how do we think about bringing more of our partnership to the village concept? What does that mean? I mean, just mapping, thinking about how do we manage the housing, the aging in place, the dynamics around the roads here, the lighting, just things like that. How do we think about that as a community? How can I get, and I've been talking about the HHS department, but I'm also thinking, like, how do I get Public Works at the table, because transportation is a health issue, right? It's not that they won't come to the table, but it's an interesting question. Or how do I get the director of community development at the table for us to think about what are the villages that we need to be designing and thinking about? And so bringing that expertise is something I'm committed to working with you on as much as I can. And I think that our staff are very focused on this work as well. And then there's a very exciting initiative, the Green Healthy Homes model, which is being led by the Marin Community Foundation. And I see some thumbs going up and some smiles and nods. I remember I talked about that slide, the broader slide around the social determinants of health that talked about going more upstream. I think this is a local example of where we have a huge opportunity to go upstream. And what I really like about it, it's called Green Healthy Homes. This is really also about health and wellness, right? So it takes, it's part of it is seeing ourselves in these broader contexts, this broader work that's being done. It's braiding different funding streams, which I think is really exciting. And it's looking at those environmental factors that we know are so important to addressing health. So, the other thing that this reminds me of is that certainly the department, certainly, the systems that we directly oversee cannot achieve that more upstream approach alone, right? It's going to take work like this, which in many cases will include government, but government may not be the sole, will maybe not even be the leader in some of this work. And I think, from the safety net side, we're very used to being sort of the holder of the safety net, and how do we work more effectively there. In this broader population health and wellness side, we have to think about health equity. We shouldn't be the only ones doing this. It's going to take a collective effort, the collective approach. So I think that this Green Healthy Homes model is a really exciting project going forward that perhaps we can build and expand upon in the future. Lots of partners, so I just wanted to put the partners up there because, again, that's what I was saying. We can't do this alone. We need your help. And I had some questions for you guys. So, just for the framework is how do we partner more effectively to move beyond outputs to outcomes, right? So again, this is a key thing that slowly is evolving at the federal level. Some of these things we have to report are just ridiculous. They're not even relevant to improving health and wellness. They're just like, how many did you check off a box? So we're trying to shift some of that. It is shifting at the federal levels. We focus again more on value-based care rather than just on, a fee-for-service model. Like from the medical side, that's where we're shifting. How does HHS become a broader community catalyst while still maintaining our safety net role? So that balance. What is the opportunity for stronger private-public partnership? And what are your recommendations for ways to move forward with regard to strengthening our data-driven, equity-focused approach? And I think that conversation will be more when we come back to you with some questions and for you to react to some more specific data we have with regard to the strategy. So I just want to thank you, and we have some time for discussion. Okay, great. So should I just stand up here and take questions? Is that the best way to do it? Okay, great.
Something I've been interested in a long time is caregivers, and especially for people 85 and over. And I've often wondered if there wasn't some opportunity with high school students who are ready to start their first jobs, who don't have grandparents in the area, for matching that up for a part-time job and trying to make that an integral part of the community.
Yeah, and there may be programs that are already doing that, but I would just say that, so it's a great idea, and I think it's something we need to think about more, and sort of, it goes back to some of it's broader, but it's more intergenerational approaches, right? So how do we think about building those intergenerational approaches? We're going to have to do that to be successful, because that peak is then going to go down for all, right? So how do we dispense and share the knowledge of these various generations together? I would love to think about more how do we do that, specifically around the high school piece. I don't know if there's anything happening in that regard, but I know that there's some models that we could look at. Yeah. Yeah.
No, we got it. Can you just come over here a little bit? Thanks, Terry.
My question is obstacles. My wife was with the Sheriff's Department for 18 years, and she was in charge of crime analysis. She told me that there are actually 22 separate law enforcement jurisdictions in Marin County, and that they don't want to coordinate anything with each other. Her job was supposed to collect data from all of them and then find patterns. And do you foresee the fact that it seems to me that every municipality and jurisdiction in Marin County wants to Belvedere? We have 2,500 people. We have our own police force. Tiburon has its own police force. Do you see those as obstacles to achieving the goals that you have?
To some degree, there are those obstacles. I guess one of the things that I would go to is I feel like one of the biggest obstacles in other counties is the social services, public health, and behavioral health departments aren't under one roof. So even trying to have a conversation to get the social services folks to the table with the public health folks, with behavioral health folks, is a challenge. And it's not that it's easy for us, but at least at this point, a year into the job, when I call a meeting, they still show up. So I think that we have those pieces that are important. I understand the challenges in terms of the various locales and sort of the locus of control. But I hope that if we can lead by data and say this is why this is important, these are the results that are showing a significant difference, we can get the public and the politicians to agree. A key example of this would be the RX Safe Marin, which is the coalition of community providers who are working on drug overdoses in the county. We have many of those departments that you're talking about at the table working with the sheriff. We have educators from, Mary Jane Burke's, 17 different school districts there. So there's a common agenda, and there's actually a structure that group has used called the collective impact approach, which really lays out a mechanism for bringing these groups together to work more effectively. It's not that it's easy, but it's certainly achievable.
As a brief addendum to that, Dr. Colfax, the older adult community is also represented with prescription misuse and medication management and falls. And really briefly, Kristen Law and Maureen Dianeva presented on that at the American Public Health Association in Denver, and 60 people were there, learning about our collective impact model. Yeah.
Dr. Colfax, you may know that the Behavioral Health Department or Mental Health Department in the county has about zero focus on older adults. How do you plan to change that?
Well, I guess I would go back to one of the slides, because we actually do have some programs. I understand it may not be viewed as enough. Where is it? Or maybe I didn't put that in the... So yeah, here we have some things that are already starting on the behavioral health side. So we actually have about 20% of the adults seen in the county's crisis stabilization unit were older adults. We have HOPE, an intensive program serving older adults with serious mental illness. And we have a new program looking at outreach for substance use treatment for adults who are older. This is, again, within the context of Medicaid, right, for the most part, with the exception of the crisis stabilization unit. So I think within the Medicaid realm, we still need to do a lot more, and we are expanding more. And just another key example with the crisis stabilization unit, for instance, Dr. Tavano, who's our behavioral health and recovery services director, just got a grant of $1 million from the state to reorganize our crisis stabilization unit, which is really in desperate need of that. That's going to allow us to provide better services and expand our services for adults in that community. I think for the middle folks in particular, the folks who are not Medicaid, and looking at that, I'm trying to figure out how we solve that as a community, because I don't necessarily have an answer to that. So I'd love to think through, some things that have come up is how do we use more lay providers, right? So how do we think about that? How do we train more people more efficiently and effectively to become behavioral health and substance use counselors? What does that look like? Do we use lay models when we need to in order to provide that? How do we look at opportunities for earlier intervention and access? And quite frankly, how do we work with some of our large health maintenance organizations to make sure that behavioral treatment is on par? I mean, I don't know if you know, but there's one major health maintenance organization in California that is being sued for not providing equivalent behavioral health care compared to physical care. It's a very important provider in the county and the major provider of county employees. And I'm a Kaiser member. So, and I'm not saying that, I want to say that within the county, Kaiser's been a phenomenal partner, and I know many of you have worked with Pat and others, and they understand the challenges here. They're struggling just like we are to provide behavioral health capacity and staffing, but your point is well taken, and I think it's a huge challenge that we need to be looking at, which is why our strategic plan is probably going to identify behavioral health as, if not the key, one of the key things for adults between the ages of 25 and 60, and then going beyond 60. I think the question is not just behavioral health, but how do we provide those integrated services so that when the dementia side is also a factor, we're able to provide that broader care. I wish I had more concrete, smarter answer, but that's...
Mental Health Services Act pours quite a few $1 million on the county, and in the act it says that I believe 20% is supposed to be aimed at seniors, and I don't think it is. I don't know what county it is, but I think it's something that should be looked at.
Yeah, we can certainly look at that data. I think it actually is, it's close to 20% in our Medicaid side of 60 and above, but we can certainly look at that data. The other thing I would say is the Mental Health Service Act requires a plan every 3 years, 5 years, 3 years. And that process has actually begun for the next generation. So we need to make sure we get behavioral health over to you guys to talk about what they're thinking about and what they're planning, because that's going to be really vitally important.
Okay, one more, and I know you have your hand up.
Thank you. A couple things. One is you talked about your zip code identifies you in terms of life expectancy. Do they have a breakdown on your website of the different life expectancies by zip code?
Yeah, we do. Mhm.
Okay, that's good. Okay.
Yeah, for those, I think the best in-depth analysis of this was done, actually sponsored by the Marin Community Foundation, called A Portrait of Marin.
Okay.
And you can find that linked at one of our websites, or Amy can send it out to the commission. Yeah.
And then in terms of, you had a slide where you identified some areas that need to be looked at, and Age Friendly uses the World Health Organization domains, and I wonder if maybe you would want to use those same domains to identify in your strategic plan what areas to look at, housing and health and information and inclusion and
That's
social isolation, all those kinds of things. So I think it might be helpful to at least look at those domains and see if they would work.
Yeah,
for your
that's a
strategic
fantastic
plan.
recommendation. Thank you for that. We'll take
And
that
then
back.
the other idea is sort of a peer counseling idea. You talked about having lay people, and I know they do that at colleges and stuff. So I think senior peer counseling might be something to consider.
And we have that already to some degree, but it's one of those things we need to expand and think about.
I know that you have more questions. And Grant, will you be here for a bit? Yeah. So if people have questions, they can talk to you directly? Okay.
Yeah, I have 10 more minutes if they're...
Do I really? Oh, sorry. If it was good writing, that would be okay.
So I have about 10 more minutes if you want to keep
Great.
going now, or do you want to...
We have to,
you have to reset the room.
reset the room and a
Okay.
break. So people can go out there and Grant can be there?
Yeah.
Good. So could we please give a round of applause to Grant? Dr. Colfax, we look forward to 6 months from now for you to come back and work with us as a focus group to share what you found in your strategic planning. So thank you very much. It was very helpful and informative.